Good evening, everyone. Thank you so much for joining in today evening. We apologize for the delay from our end, and let's begin you know, the, without further delay. So we are here for the cardio colloquium, and of course, Dr. Heman Kali doesn't need any introduction. Sir is the chairman of the National Intervention Council of CSI and the director of the Interventional Cardiology BM Birla Heart Research Center, Kolkata. We also have our esteemed faculty today for the discussion. We have Dr. Panchan Sahu. Sir is the head of Department of Cardiology at
A little
KIMS.
correction. I'm sorry. I was the ex-chairman of NIC, and I am the president-elect for this cardiological society this year. So sorry for that. I don't know who has given it, not mine. Yeah. Thank
Okay,
you.
okay, sir.
Please proceed.
Apologies for the same, sir. We have Dr. Abhishek Goyal as well from Ludhiana. Sir is the DM Cardiology, DMCNH. We also have Dr. Rajiv Avasti. Sir is a diabetes and medicine specialist currently at Lucknow. We also have Dr. Abhishek Gupta. Sir is the director of Department of Cardiology at Sarvesh Health City, Hisar. And finally, we have Dr. Rahul Arora. Sir is the DM Cardiology and working at Felix Hospital, Noida. So we welcome all of you here today for a wonderful discussion on 30 years of air to ARS navigating RAS inhibitors in post-MI patients. Over to you, sir.
Okay. Thank you. Okay, I can't change it.
Stop sharing, sir.
So it's not moving from here.
Uh, Sir, I can stop sharing or
Okay. Okay.
yeah,
Let me try from my end.
yes, please.
Question না তো? Share. হবে না না? এইটা যাবে শেয়ার হবে চলবে এটা আসছে সরছে
Just try sharing the screen directly rather than a single tab. It'll be easy.
we are sharing the screen only.
Dr. Kali?
Yeah. So today we are going to talk about.
So your screen is not visible.
It's not,
I'll do one thing. I can share the screen from my
I
end.
can see it here. Okay. Then
Yeah,
you
yeah.
show it from your end.
Yes, sir, I'll do that.
But it was moving and showing to me at least.
I think there's some network lag, sir. Let me know once my screen is visible to all of you.
Okay. So
It's
it's
visible
visible.
now.
Perfect. So, sir, you can go ahead. You just let me know. I'll keep changing the slide.
So today we are going to talk about, first of all, I apologize again to the distinguished panelists, and it's great privilege for me. I know Panchanun Shahu personally and others also a little bit, and it's my privilege to talk with them, such a distinguished panel of cardiologists and interventionists. And this is a very important issue because this. ARNI is a very expensive molecule till now. Of course, some of the molecules have become very cheaper, but they're generic. And that's the main factor, I think, that where we should think, where we should use more of AC inhibitor or ARB. So it has been
Sir, we can't hear you.
Yeah, but it's going and coming like that. I don't know how far we can talk. See,
Now, so you can
going.
stop sharing your video. Maybe that will help with the network. So we could hear you now. You can please continue. Hello, sir, are you there? Hello.
I think network issue. The team is checking. Who is present over with Dr. Dhiman. Just, yeah.
It's not audible now.
Yes, the team is present there. He's checking. Just quickly, we'll resume. Yeah.
49.95. Into 55.35. Hmm.
कितने टाका मिला? One minute. Sure. तक्को minute पे होगा तक्को. 1 minute होगा.
Sundarji, sir is rejoining.
Okay. Okay, Sumanta.
Okay. Any updates, Sumanta?
मिनिमल इन्वेजिव बताओ आप क्यों कर रहे हैं बहुत जल्दी अरे ये क्या वो दिखाओ ना आपका पढ़ो तो अच्छा ड्रामेटिक सेक्रेटरी टू
रौनक सर आई थिंक डॉक्टर पी विश्वास लैपटॉप से ज्वाइन किया है
Okay.
हाँ तो सर कैन यू when your
Sir,
video
can you
and
just
audio-
unmute yourself?
yes
Dr. Kali?
हेलो सुनाई दे रहा है कि नहीं मैं चेक कर
Yeah, Sumanta, you are audible.
Sir. Sir, actually,
Sumanta, he can also join from your audio. It's fine.
yes रौनक
Yeah.
जी मैं
So, thank you. We have tried another one, and now I think we can continue. So, you just share the slides, and I shall talk on it.
Right. You
So it's
telling
not
me
very
to change the slide.
comfortable, but what's the? Yeah.
Right.
Yeah, I can see the slides. So, as I was today's talk, the main theme of the talk is that we have been using ARNI in chronic heart failure patient. There is no doubt that it is a good molecule in paradigm HF. and Paragon HF with ejection fraction more than 40%.
Sir, we can't hear you. Sumanta,
Yeah, Ronakji.
are you there in the chamber with the doctor?
No, my colleague is there.
Can he join from his phone and sir can just
Okay.
dictate the slides?
Okay.
I will keep
Okay.
changing, please.
Okay.
Vascular mortality and also hospitalization or emergency visit for heart failure. All these three components, which were the primary objectives, are not statistically different. P-value was 0.17. But numerically, in the sacubitril group, it occurred in 338 patients against 373 in the RASI group. RASI means this enalapril and not ramipril really, enalapril and ARBs in intolerant patients to AC inhibitors. So there was no significant, though the hazard ratio was 0.9 and 48 patients needed to be treated to get some advantage, but it could not prove the statistical significance. On the other hand, the review of both these trials, it was found that with reduced ejection fraction, as we know in the paradigm HF, the LV work with less than 30%, it was to AC inhibitors. But post-MI, the situation is something else. And in the Paradise trial, which will be coming after a few slides, we'll discuss in detail about the Paradise trial. And it was found that AC inhibitors are not inferior to ARNI, and they should be used post-MI. And so TCDMD, after the publication of Paradise trial by
Dr. Kali,
one of my good friends,
Dr. Kali, sorry to interrupt you. Sir, are you sharing the screen or something? We cannot see it. And the slides which I am sharing, if you can just let me know, I'll keep on changing accordingly.
Yeah, I know. I'm just telling I can see your slide, the post-MI. Okay. That is what I am telling, ARB, ARNI, and ACEI, the guidelines, suggestions. So you can see the slides, but I don't need the change of slide. Let me talk for 2 minutes, and I would appreciate no interruption during the talk.
Sure, sir.
Thank you so much. And yeah, so when I tell you change, you please change. So because the flow of events get jeopardized. And the other parameters like all-cause mortality and others were also not different. Here you can see the comparison post-MI. In Paradise trial, it was my Mark Pfeffer from Boston, from Brigham Hospital. He's a good friend of mine, and he was behind the Top Cat trial also. And he postulated that in Paradise trial, post-MI, AC inhibitors and ARNIs have no statistical difference. That means we can use AC inhibitors, and because it's cheaper and the outcome is same. And also our experience, patient years of experience is more with ACEI or ARNI or RASI as a whole, AC inhibitor oblique ARB, AC intolerant patient, like in our country, 20% patients can't tolerate ACEI. So in those group of patients, we can think of the ARBs. So that being the situation. Next slide, please. Next slide. So let us recapitulate the history a little. So this was first of its kind optimal trial. Losartan 50 was compared with captopril 50 milligrams 3 times a day. And again, there was no significant difference in total mortality in favor of captopril. Again, regarding the Valiant trial with 14,700 odd patients, valsartan is as effective as captopril in patients who are at high risk for CV events after myocardial infarction. Combining valsartan with captopril increase the rate of adverse events with improving survival. We know the outcomes of this combination, AC inhibitors plus ARBs. They are not at all to be given and they are not desirable. Next. So we can't mix AC inhibitors with ARBs. This is a few more slides regarding the optimal trial, which was published during the pandemic. Optimal trial in myocardial infarction with angiotensin 2 antagonist losartan. Non-significant difference in total mortality in favor of captopril. AC inhibitors should remain first choice treatment in patients after complicated acute myocardial infarction. What I have been talking during the last 7-8 minutes. So the gist of the issue from optimal trial also, after MI, only AC inhibitors should be used. Losartan cannot be generally recommended in this population. So captopril is better than losartan in this optimal trial. Next one, please. You can see the curve. This is again a very famous trial published long back in 2003, 22 years back, valsartan in AMI. Mortality from any cause and cause-specific mortality were similar in the three treatment groups. The rate of the secondary endpoint of death from cardiovascular causes, recurrent MI, or hospitalization for heart failure were similar in the three groups. That means only valsartan, only AC inhibitor, or a combination. So it was no difference, and you can see against placebo there was no difference in this. You can see all the curves are superimposed. Next one, please. No, I think you are going behind. So yeah, next one. Yeah. So this is the Paradise MI trial, as I was telling my friend Dr. Pepper. He's an old person, of course, he's much older than me. And he was behind the Top Cat trial, was also a good trialist. And he was the PI and the chairman of the steering committee of this Paradise MI trial. And this is full name is angiotensin receptor neprilysin inhibition following acute MI, primary results of the Paradise MI trial. As I told you, he's from Brigham and Women's Hospital. And for the next one, please. He was the national lead and investigator. And this is the inclusion criterion that AMI half to 7 days with LVF less than 40% and or pulmonary congestion. And these were the risk enhancers. So a very high risk group of patients were included in Paradise HF trial. Aged EGFR less than 60, diabetic patients, prior MI, atrial fibrillation, enhancers, LVF less than 30%, class more than 3, that means heart failure patients with bilateral cramp, STEMI without reperfusion. And major exclusions, prior HF, instability, EGFR less than 30. These are the exclusion criterion that if a patient had prior heart failure or the patient is very unstable, we don't get any patient in the trial if the patient is unstable. That is one of the primary things we do. And EGFR less than 30, that is also an exclusion criterion in all the trials almost. So ramipril target was 5 milligram BID in this trial. So you can see, as opposed to other trials, of course, in ARE, ramipril was compared. But here you can see that ramipril is compared with the sacubitril valsartan. And I should again tell that, see, sacubitril valsartan was used in a dose of 200 milligrams twice, means 97 and 103 BID in 2,800 patients. And in another 2,830 patients, same number, ramipril was used in a dose of 5 milligrams twice a day. And this was a double-blind, actively controlled, event-driven, and the event numbers are designated in such trials, and it was 711, and medium follow-up was for 2 years. And the primary endpoint was CV death, heart failure, hospitalization, and outpatient development of heart failure, as I discussed earlier. So these are very important endpoints. And you can see that not even heart failure, hospitalization, but outpatient development of heart failure is also a criteria, as it is in case of worsened heart failure. Similarly, it is also a point over here. Secondary endpoint is CV death or first heart failure hospitalization. So the primary outcome, CV death, first heart failure and hospitalization, or outpatient heart failure. So you saw that in worsening heart failure where basic what is used, that becomes an indication. These are the factors which come into play, that heart failure, hospitalization on outpatient heart failure. So these are the new variations by the European Society of Cardiology. And as I was telling that the p-value is 0.17, exactly what I told, and hazard ratio is 0.9, and sacubitril valsartan group 338 events, 6.7 per 100 patient years, as opposed to ramipril 373 events, 7.4 per 100 patient years, so little more. But you see down within the red square, you can see p-value was 0.17. So statistically, it was not significant, though the hazard ratio is 0.9 in favor of sacubitril, and the numerical numbers were little less, but it did not get any statistical significance. So that's very important, and we can't recommend that. So the TCTMD opined. So these ARNIs are no better than AC inhibitors post-MI. And in some make space, in some news item, they have written, have we to think again about ARNIs? So these are their comments in make space. Next slide, please. After this, Paradise by Mark came, and these were the comments in the newspapers. C is the educated primary outcome. As I told event rate, you can see we mentioned this is the third time I'm mentioning on the event rate 338 versus 373 with p-value 0.17 and hazard ratio 0.9 with a confidence interval of 0.78 to 1.24. And CV death was 168 in the sacubitril arm, little numerically again less. But see again, this did not attain any statistical significance. That is 0.2. And heart failure hospitalization again 170 by 195. In the ACE group, and outpatient heart failure 39 versus 557, 2% versus 1.4%. So there is little difference in both the groups. Next one, please. Now, you can see the other parameters, hypertension, 802 in the sacubitril group as opposed to 620 in the other group, cough 255. It's not that cough doesn't occur with sacubitril, it occurs with sacubitril. Incidence is little less, and it occurred in 620 patients in 2,800. So you see, some people tell that when I tell in many conferences that, the incidence of cough with AC inhibitors is almost 20 to 25%. Some patients oppose me and tell, no, it's 2%, 3%. You see, in trial with Coversil, it was only 1%. No, it can't happen. You bring those population and we'll find out how many patients had to discontinue because of it. This is not truth. This cannot be truth because we are seeing the Indian population and we can tell that at least 20 to 25% of patients get intractable cough, harassing cough, dry cough, without any flames usually in this sort of patients who are post-MI, and cough is not infrequent though in ARNI patients. The renal impairment, same almost 329 and 326 or something like that. So it's same hyperkalemia also, more likely in the AC in the ARNI group than in the other group. And liver abnormality is also more common in the sacubitril valsartan group in comparison to the other group. Now, to summarize, ladies and gentlemen, regarding this trial, Paradise sacubitril valsartan did not result in a significantly lower rate of CV death, heart failure, hospitalization, or outpatient heart failure during treatment. Pre-specified observations of reductions in both the investigator reports of the primary composite as well as in the total attributed events support incremental clinical benefits of sacubitril valsartan. The safety and tolerability of sacubitril valsartan in this AMI population was comparable to that of ACEI. So it's not no different, it's almost same. Next. These are very significant inferences from this trial. And as I was telling, that comments post the release of Paradise MI headline results. Paradise MI aren't, this is from TCDM, TS. I told you, ARNI doesn't surpass AC inhibitor after acute MI. Paradise MI makes me questions the benefits of sacubitril valsartan. This is a newspaper, and it was shown by American College of Cardiology in their website. And you can see the comments in MedSpace by John Mandoria and others 2021 during full pandemic, May 16. So people were not inactive. They're working hard even that pandemic period with corona infestation and so much of death over there. Next, please. So these are the various sarcastic comments. Next one, please. So again, this is the first slide, which I think, and ACI post-MI trials, you can see. And go for some discussion because otherwise it will become monotonous. So I would advise you to moderate ask the questions. First, I would like to ask Panchanun Shahu, Professor Shahu, who is a good friend of mine, to give your opinion, Dr. Shahu, regarding all these recent developments during the pandemic. So,
Thank
Dr.
you,
Shahu,
sir.
please.
Am I audible?
Yeah.
Hello.
Panchanan, you are fully audible.
Yeah.
Yes,
Thank you,
sir.
sir.
Fully audible. Yeah.
Thank you, sir. Hearing your opinion on the Paradise MI trial, I think for last more than 25 years after IR trial, we are using Ramipril as a #1 drug after MI in post MI. But we have recently this sacubitril valsartan with Paradise MI. It is almost equal result or some decrease in the not exactly mortality, decreased hazard ratio has been seen in our
Hello.
Yes, very good comments, Dr. Shahu. You are a very experienced cardiologist, so your talk and your comments are very vital to all of us. So next, I should come to Professor Abhishek Goyal from Ludhiana. Are you there, Dr. Goel?
Yes, sir, I'm there.
Yeah. So, Dr. Goel, please tell your opinion regarding these new concepts.
First of all, Dr. Kali, it's a very elegant talk. I am
Thank
here.
you very much. Thanks, Abhishek.
Yeah, I'd like to introduce myself. I am Professor Cardiology. We have a medical college called Dayanand Medical College. And
Very good.
the cardiac unit is Hero DMC Heart Center. Dr. Gurpreet Singh Wander is the chief of my department. So me and Dr. Wander, we are working together.
Yeah, Dr. Wander is a good friend of mine. Yeah.
I know, sir. You are mentioning that you're president.
Recently, we had a lecture. We had a very keynote address. I and Dr. Gurpreet side by side. Immediately after me, he was the lecturer, and he praised me a lot. So, how is he? And give my regards to him.
Surely, Dr. Kali, I will. And my second, you can say mentor is Dr. Sanjay Tyagi, because I'm basically from GB Panth. So these two are my visiting cards to Dr. Kali today. Dr. Kali, regarding my comments, first of all, these people are asking, they have asked me a very, strange question that if a patient with myocardial infarction comes to you, would you switch over from ARB to ACE inhibitors? If your patient is already on ARBs, would you switch from ARB to ACE inhibitors?
No, I will give SC inhibitor because, and I will give ramipril 1.25 to start with because, this is a long story cut short. In 1981, if you look at the history, I read that article, I remember on the right-hand side of NEGM, 1981, probably October issue, 30th October or 1st October, I don't remember. Dr. Eugene Bronwell, none other than anybody, wrote that after a heart attack, we have seen that there is a gradual enlargement of the left ventricle by 1 ml per year. And it can be prevented or partially prevented by molecule like ACE inhibitor like captopril, which should be started with 6.253 times a day, and then you can increase it. So that started the ball rolling. And after that, long, many papers, many things, ARBs has been tried. At one time, it was told that telmisartan increases the incidence of MIs, which were found to be rubbish later on. But still, I would prefer to go from AC inhibitor. If the patient is AC inhibitor naive, I would like to go from it to ARB, to AC inhibitor. Sorry, from ARBs to AC. Means ramipril or something else.
I agree with you because these patients are hemodynamic.
Because in heart failure, AC inhibitors are number one. Then ARB. It is a default. If they can't tolerate, if there is somebody is intolerant to the drug, then we can think about ARBs, not initial.
Okay. So I'm coming to my comments again. ACE inhibitors, yes, because these are hemodynamically best tolerated. As you mentioning that you start with low dose of ACE inhibitors, but it also depend upon the blood pressure of the patient. And if you look at the data that you just showed us, the data with ACE inhibitor is robust. It's huge. But if you look at ARBs, there are only two trials which you mentioned, Optimal and Valiant trial, where the ARBs are found non-inferior. So we don't have data to support ARBs as first choice as compared to ACE inhibitors. And as you already mentioned, that Paradise AMI trial, these ARNI were found to be non-inferior. But I would take the results of this Paradise AMI trial with the pinch of salt in a fact, in a matter, in a sense that these patients had a very high incidence of hypotension as compared to ACE inhibitors. So if you have a hypotension occurring in a MI patient, it can actually derail your patient. It can actually unstabilize your patient and start a negative downward trend in terms of stability. But again, coming back to this question, if you talk about ARB and ARNIs, I think the data doesn't support because the data is not robust. So I would say that these drugs are underrepresented as far as trials are concerned. We need more trials, but I agree with you, ACE inhibitors in this scenario is the first line choice. First line agent.
বিএমএল খুব সিকিউরিটি জ্যামার ফ্যামার লাগিয়েছে, এটা তো অ্যাপেলের ট্যাব করতে মানে আটকাচ্ছে।
Yeah, we can see the slides again. There was some interruption. Yeah. Abhishek, any more thing you want to talk?
No, sir. I think.
No, you can tell if you wish. You can tell anything.
No, both of us are in alignment as far as this
Okay.
question is concerned.
Okay, very pertinent. Though you are a young cardiologist, but whatever you told is like a veteran cardiologist, and you have talked about very valid points that AC inhibitors are the time-tested drugs, not the ARBs, neither the ARNIs following an acute MI. So the message is very clear-cut. And also from another aspect, Vishek, and to all other faculties here, I would invite your comments also, that cost-wise also this molecule ramipril is much cheaper. And it's very easy to build up the dose. So from 1981, from Brownwald's article, we know that it prevents cavity dilatation, which holds still now. It prevents the negative remodeling of the left ventricle. It is also helpful in preventing or causing positive remodeling of the vascular wall. So that's very important. We think only AC inhibitors do positive remodeling of the left ventricular cavity, prevents the cavity dilatation, this and that. It prevents the onset of atrial fibrillation in some cases, or some other lethal ventricular arrhythmias by increasing the potassium level or making the patient eukalemic. But apart from those things, I think very important that this molecule stabilizes the patient as a whole and prevents the cavity dilatation and prevents the progression of the disease like carvedilol, because we know that carvedilol was given FDA approval by the fact that prevents the progression of heart failure. Thank you very much, Abhishek, again. And next I'll come to Dr. Rahul Arora, cardiologist, Felix Hospital, Noida. So, Rahul, can I ask your opinion, please?
Sir,
Dr. Rahul Arora.
Sir, already previous faculties have answered this concept about whether we should use ARNI or
Anything new you want to tell? Anything new?
No, sir. I think both the points, whether that is hypertension, I think the ACE inhibitor are the first choice in post-MI patients. Hypertension is very common with ARNIs. So, and moreover, the Paradise MI trial has shown that ACE inhibitors are better than ARNIs in terms of hypertension. Post-MI patients are very fragile, and if there is as Dr. Abhishek Goyal has pointed out, that hypertension can be detrimental for post-MI patients, especially after revascularization. So I think ACE inhibitors can be used as low dose.
Really? Okay, thank you very much, Rahul, for your very valid comments. And next I'll come to Dr. Rajiv Awasthi, medicine and diabetic specialist from Parthana Diabetic Care Center and Clinic, Lucknow, Uttar Pradesh. We were in our CSI meeting last December, first week over there. So we had the annual meeting of Cardiological Society of India. So a 76th one. So Dr. Rajiv Awasthi, please, your comments, please. Dr. Rajiv. Dr. Rajiv.
Dhiman sir, Dr. Rajiv, I think he logged out. Maybe he will rejoin. Maybe sir, meantime you can pick any.
So if he rejoins, we'll come back to Dr. Rajiv. If you are there watching the procedures, please come back and give your valuable comments. And next we'll come to again to Dr. Abhishek Gupta, Director and Department of Cardiology, Shalves Health City Hospital, Hisar, Haryana. So, Dr. Abhishek Gupta, please. Dr. Abhishek Gupta. We have heard the opinion of Dr. Abhishek Goyal. So now we are asking for Dr. Abhishek Gupta. Are you there? Yeah, please. Dr. Goel is there, I can see. Thank you. And about Dr. Abhishek Gupta, I think he is not also in the meeting, I think.
Maybe.
Yeah, Mr. Bharadwaj, I think he is not in the meeting. He has left out, we are late, so I am the accused person. Anyhow, so can we proceed now with further slides?
Yes, sir.
So this is regarding the SAFE trial, which was one of the study. You can see I was talking about that Eugene Brownwell pointed this out. 90% reduction. And you must remember the maximum benefit by this AC inhibitor achieved if we start with 24 hours following the acute MI. That's very important that it should be started immediately after an MI as early as possible. And one thing I can tell, even the patient's pressure is borderline, say 90, 88 meters. Don't hesitate to start AC inhibitor in a dose of 1.25. It reduces the dose of diuretics if you want to give on the dose of AC inhibitors because these are the anti-age molecules and they will prevent occurrence of the impending failure. The chemical agitation is reduced, as we know from that article in GM 1981. These benefits occur equally. See, this is in 1992, after 11 years after Brownwell wrote. Therefore, we just respect him. And if the organizers permit a small news to you that Dr. Eugene Brownwell and Dr. Eric Topol have given a consent to have a joint meeting with us. They will be televising their broadcast, their lecture from there regarding the future of cardiology. Dr. Brownwell will be talking on that during our next CSIA conference to be held in our capital, New Delhi, and it will be presided by Dr. Jagat Narula, the president of World Heart Federation. So I invite all of you, kindly register your name, kindly come, and if we can come to any of your services, please tell us, and please join the meeting. It is a very good meeting with a lot of clinical relevance, lot of clinical information, latest of information, and you'll be able to see Dr. Brownwell. So those benefits occurred equally in patients who received lysis plus beta blockers and in those who did not. So this is a comparison that those who received the lysis plus early beta blockers again, the benefits were very evident. And the dose building of beta blockers in this situation, even though patient's ejection fraction is less, not like in heart failure patient, where we double the dose every 15 days and start with the lowest possible dose. Here also we start with the lowest possible dose, unless the patient is hypertensive. Otherwise, we start with the lowest possible dose and double the dose every 15 days. And Ramipril, of course, we can go quickly. So any comments about this slide, SAFE trial data? Just who wants to tell, please come. Dr. Shahu, Dr. Goel, Dr. Awasthi, Dr. Gupta, have you joined? Abhishek Gupta. So let us go to the next trial, next slide. TRACE trial, Trandolapril studies in the control center trial, AMI with 107 patients between 3 and 7 days. Trandolapril was given a dose of 1 milligram per day, maximum of 4 milligram versus placebo for 2 years to 4 years. And there was a 25% reduction in mortality, 15% reduction in recurrent MI, and 20% reduction in sudden cardiac death. And we think that many of the deaths were prevented because of occurrence of this arrhythmia. Next, please. This is some trial in post-MI ACI use, that is ISIS-4 with 58,000 patients. Huge patient base. Captopril was effective in reducing 5-week mortality. The survival advantage appeared to be maintained in the longer run. And then came the GC3, which showed that in 18,900 patients, almost 19,000 patients, lisinopril started within 24 hours after MI. So early start of the molecule following the MI is very important. Effective mortality and severe ventricular dysfunction is reduced to a large extent. And CCS1 with 15,000 patients, and it was shown to have lower mortality. Next one, please. So this is the ARE trial, and you can see that there was a 27% relative risk reduction. The blue one, the upper one, is placebo. It's a mortality curve, Kaplan-Meier mortality curve, and the red one is with ramipril, and there was a 27% relative risk reduction of mortality, and there was some reduction in the blood sugar level also. An acute MI with transitional or persistent heart failure, randomized between 3 and 10 days, oral ramipril 5 milligrams twice versus placebo, and the follow-up was for 1 year, 3 months. And ramipril group showed 27% relative risk reduction in mortality, 19% reduction in rate of MI and stroke at 6 months. So a significant finding from ARE trial in acute MI population. And the numbers were also fairly large. The results are encouraging for AC inhibitors. Next one, please. This one is the extension study. In extension also, it showed there was a 36% relative risk reduction, and p-value was highly significant, 0.02, 202 rather, and hazard ratio was 83, and placebo was 117. So it is significant. It reduces mortality and heart failure hospitalization like the other trials. Next one, please. Again, ramipril's long-term survival benefit acute MI patients complicated by heart failure, ARE survival, ARES trial 2021. To assess the long-term 30 years after randomization magnitude of impact of length of survival observed after treatment with ramipril. Last dose is 5 milligrams twice a day. Results median survival time was 8.3 years with placebo and 9.6 years, much better than with the other group. And extension of life is 1 year and 2.5 months. Survival curves cross at 14 years from the lifetime of randomization. Life experience was retested about 15 years. So life expectancy was improved with the favorable molecule for increasing the life expectancy, like the metformin in diabetic patients or SGLT2 inhibitors. The latest favored molecule. Next one, please.
Next one, please.
Yeah, so results, this is the very busy slide and relative risk of survival. Don't go, please. I have not finished the previous slide. Substantial survival gains with ramipril for 15 years beyond the blinded period. Overall, for every day a patient received ramipril on average, his or life was extended by a further day. That's very interesting. Relative risk of survival for patients with diabetes was increased by 54%. And treatment with ramipril for about 1 year when started early post patients with heart benefit which is sustained over many years and offers on average an extension of life in addition to 1 year or so. So that's very important. Opinion of the house, anybody can comment, or house gathering, faculties, any comments? Concluding remark, treatment with ramipril for about a year when started early post-MI. That's very important. Immediately after the MI, it should be started, even if the patient is hypotensive, even the patient is, some having dyselectrolytemia, it has to be started, and the dyselectrolytemia has to be started. Continue. And treatment with ramipril for about 1 year when started early post-MI in patients with HF results in survival benefit which is sustained over many years and offers an average extension of life of an additional 1 year. We can't tell how much it is exactly. Next one, please. Next slide. So, should I conclude over here with the comments from my co-chairs?
Okay, I can comment. You have very clearly told us that ACE inhibitors, especially this ramipril, is very, very useful drug in MI, and it adds to, it results in a reduction of both heart failure symptoms as well as it decreases the mortality. Now, this slide is about the timing of the introduction of ACE inhibitor in myocardial infarction patients. Well, all the guidelines they clearly state, and even the data support that ACE inhibitors should be started as early as possible, ideally in first 24 hours, unless patient is hemodynamically unstable. So it has been shown earlier you introduce ACE inhibitors, the better are results in terms of early function recovery as well as mortality. So long term, it is quite, this strategy is very, very useful.
Yeah, that's right. Yeah. So, any more comments from anybody else? Webinar, please ring me after an hour or 1.5 hours. So anyhow, so these are the few slides, and to summarize the issue, this molecule, this ramipril, which is a class from the AC inhibitors, is a very useful molecule. I have a long experience with this molecule, and apart from cough, this molecule is very safe. And also, I recommend that in borderline cases of hyperkalemia, we can go with this molecule. You give some furosemide, you give some, if the creatinine is little elevated, you can give some sodium bicarb. And by this, we can reduce the potassium a little, but okay, if it's very much high, then we can have to think about Localma. Localma is not available here because Sanofi was initially very interested to bring this molecule, but seeing the results in Kolkata. So like that, ramipril we can use even in borderline hyperkalemic patient along with Localma. That is the sodium zirconium, which is some authorities are claiming that it is which I doubt because it contains a lot of sodium. It has been shown by some physicians like Dr. Mears and others that they can increase the amount of, and Dr. Frank also, he was also telling me, he was the president of the American Heart Failure Society, he was telling me that it's a sodium zirconium salt, Localma, and another name is Patyromere, and they can increase the sodium and precipitate heart failure. And I believe there is a small article in some of the peer-reviewed journal written to the editors as a letter or something like that, that this molecule should not be given in heart failure patients right and left, which is being done in UK and Europe. They use very frequently zirconium, and the threshold for starting zirconium is also very low in patients with severe heart failure, because when the hyperkalemia supervenes, we can't give RASI or ARNI or ARB, anything. So the choice becomes, treat the patient with hydrolysine and isosorbide dinitrate. But this combination, we know this is not going to help in the long run, because there is a high sodium salt in zirconium and the localma, and so that can again precipitate heart failure. And there has been comments that it worsens the heart failure actually. But in Europe and UK, it's being used till now very frequently, especially in the borderline, hyperkalemia patients. So it's an issue till now. And let us see what the result comes. Let us hope for a randomized data with localma, which will show that whether it can come as a fifth down foundation therapy or it will be an obsolete molecule. So thank you. This is all from my side. So any comments from the organizers or any of the faculties over here? If you have any comments, please kindly give your comments.
Surendra, do we have any questions from the audience?
Just give a moment. I'm just checking.
Yeah.
Yeah, Dr. Ronak. So I think the questions are moreover comparing the the usage of ARNI early into the post MI space. Doctor, how do you see although you have answered, so just if you can re-emphasize on that, this is what the maximum questions are.
Hello. Yeah, so I think we have discussed all the pros and cons of this molecule in acute MI, but it's very important that sacubitril is non-inferior to this molecule. So post-MI, at least, I don't use personally also sacubitril valsartan. Rather, we use unless the patient is intolerant to ARB. If the patient is intolerant to ARB and there is severe LV systolic dysfunction, then of course we think of this molecule ARNI. So that's my perception of the case, and it's equally good. And we all long know for long, almost 45 years now, that Brownwald has written an article in NEJM in 1981, and after that, long after that, in 1992, paper and others brought this issue. And secondly, this this has been internationally accepted that AC inhibitors are well taken and well tolerated in this population with heart failure.
Okay. Thanks a lot, doctor. So I think no further questions, sir. I think because we have reached almost the time, so we can conclude this and end this session.
Yeah, thank you so much. Thank you. Thanks all thanks the doctors, thanks the organizers, thank Dr. Ari, Dr. Bharadwaj, and everybody to have such arranged for such a beautiful meeting. So good night, and I wish you all a very, very happy weekend in front after a few days. So all of you, and again I would request you, please come and join Cardiological Society of India annual meeting in Delhi from 4th to 7th of December. And Dr. Brownwell, who postulated this theory that there is dilatation in 1981, because he's a legend, he's a visionary, and let us listen from him what is the future of cardiovascular disease in 2005. Thank you so much.
Thank you so much.
Thank you very much, sir, for joining us.
Thank you, everyone.
Good night. Good night. Thank you.
Good night. Good night, sir.
Good night.
Night.
Good night. Thank you very much.
Thank you.